Good afternoon, everybody. We are so excited to have you join us today for our very special guests, Dr. Benjamin Lee and Dr. William Raszka, pediatric infectious disease physicians from the University of Vermont. They are going to share with us a little bit of information about where things stand now with COVID-19 and children, and then we'll open it up for questions. Please put your questions in the chat box, and we also have gathered the questions that were sent to us earlier, and we'll be answering those as well. So let's get started. Go right ahead, Dr. Lee.
All right, thanks for having us. Glad to be here. And so we thought we would just start off by giving a brief, just a brief presentation about some of the more recent studies that have come out that have been causing some controversy in the media, just as a primer for getting our conversation started. So I'm going to take over sharing the screen. All right, and can you guys all see my screen okay? All right, so like I said, we just wanted to go through some of the more recent happenings that you may have heard about in the media, starting with the recent report about the camp outbreak in Georgia. So this was released in the MMWR at the end of July. I think a good alternate title for this report is How Not to Reopen a Congregate Setting, for the reasons that I'll get into in just a second. So this was an overnight camp in Georgia, and they had discussions and plans for trying to perform mitigation within the camp setting. But at the end of the day, here's what ended up happening. They required all campers to have a negative test within 12 days prior to entry. So while they made an effort to show that everybody was negative coming into the camp, everything we know about this disease right now, it was clear, you know, to me, as soon as I read that was going to be insufficient, because in an area with lots of community transmission, as Georgia was experiencing at that time, that window between the test and entry into the camp was just too long. So there could be lots of people who got infected anytime within those 12 days, yet would show up to camp with a negative test, but be unknowingly infected when they entered camp. Next, the mask or the camp did not require campers to wear masks. They required staffers, but they made the decision that they were not going to require the actual attendees to wear masks. And I would argue that you know, the longer and longer the pandemic has gone on, the more and more we recognize the importance, the vital importance for everybody to be masked when they're going to be around other people. Additionally, you know, going hand in hand with that is the recognition that that ventilation is important. So doing whatever we can to increase the amount of ventilation is a good goal to work towards. And they were in a scenario where they intentionally left windows and doors closed, and were not doing the recommended measures to try to increase airflow within the camp buildings. And finally, the kicker was that every day, both indoors and outdoors, they were having campers gather for vigorous activities, including singing and cheering. And so this is a perfect storm. So everything that we know about the virus to date would argue that you know, asymptomatically infected people not wearing masks in a closed indoor environment, vigorously singing, that is a recipe for disaster. And that's unfortunately what happened here. And I also put in this figure to show what the context was during the time that this camp was operating. So this is the FB curve for Georgia, how many cases per day. All the staff arrived on June 17th. On that day, the state had 915 new cases. On June 21st is when the campers started arriving. That day they had 824 new cases. And the first camp session was 1 week, scheduled to go through the 27th. That day they had over 1,500 new cases. Now, if you compare that to Vermont, where we've just barely now, I believe, eclipsed the 1,500 case rate over the entire course of the pandemic, those are the numbers that they were seeing daily during the time that the camp opened. So there's a lot of community transmission going on at the time. So I say this, present this because I think there are important lessons to be learned, namely that in the school environment, masks are a good idea. Trying to improve ventilation is a good idea, and making sure we're not engaging in activities that we know promote the spread of the virus is a good idea. And those are all things that we have been very careful to address in the reopening guidelines between the Agency of Education and the Department of Health. So at the end of the day, the first positive patient presented on the 23rd of June got a positive test result the next day, at which point they started sending the campers home. But when all was said and done, about half of all attendees, both staff and campers, ended up being infected. Only a minority of folks had symptom data that the CDC investigators were able to retrieve. About a quarter of everybody was asymptomatic, but in those who did have symptoms, the most common complaint was fever. So I do think taking temperatures, there is a role for taking temperatures, followed by headache and sore throat. Okay. The next study that's been receiving a lot of press recently, although with how rapidly news cycles these days, maybe this is already ancient history, but there was a paper that came out just less than a couple of weeks ago that made the argument that in children, they were finding very high amounts of virus in the nose of children infected with this virus compared to adults. And basically, what they did was using a technique known as real-time PCR, they were able to detect the amount of the genetic material that's the amount of RNA, which is the genetic material of the virus, in the noses of children, both young children, children 5 to 17, and those greater than 18. And what they find is that using PCR, the amount of virus that they find in children less than 5 did appear to be significantly higher than in adults greater than 18. And they estimate that as anywhere between 10 and 100-fold higher. It's a little bit confusing because for PCR, a lower number, so the median, what we call the cycle threshold or CT value, a lower value means more virus. So a value of 6 is about anywhere from 10 to 100 times higher than a value of 11, which is what they were finding in the adults. The caveat here is that all that PCR can tell you is the amount of the nucleic acid present. PCR CT values by themselves doesn't tell you anything about actually how much of what they're detecting was infectious virus, meaning capable of entering somebody else and causing a new infection, or how contagious it is. So if you took all the virus that was in that sample, killed it, and then ran the same test, you would get the same result, because it can't tell you how infectious that sample is, or how many mature viral particles there are that can then go on and infect somebody else. And furthermore, it doesn't give you any indication for how well the child can actually get the virus out of their own body and into the environment or into the surrounding air where it could potentially infect somebody else. We know that with other respiratory viruses, this is something we see. So we see the same pattern with influenza, for example, where young kids have much higher virus levels than in adults. The difference is that in influenza, it's very clear that young kids can really easily transmit the virus. However, with this virus, all the evidence still continues to suggest that young children are very inefficient at transmitting the virus to other people, even if they could potentially have as much virus in their own noses as adults. And then I think that is an important distinction that we need to keep in mind. And then finally, there was recently a study, this was a statistical modeling study that tried to look at the association between school closures and the incidence of COVID-19 and mortality in the US. And without really getting into the nitty-gritty details, the challenge with this study, the headlines were school closures saved X many lives or prevented X number of infections. It's possible, but the problem is that pretty much all states in the country enacted a whole bunch of different interventions in rapid succession, meaning that it was impossible to tell which intervention really was driving this effect. And so, and one of the other things that they saw was that the greatest effect of closing schools was seen in areas that had low cumulative incidence. In other words, places where schools closed and had a big effect was in areas that were already doing well in terms of managing the virus anyways. And so, my interpretation of that is that those areas where the incidence remained lowest are those areas where everybody was just sort of doing the best job following all the rules and limiting viral spread. And I don't think it's fair to say that the school closures themselves are what was responsible for that. All right, so I'll turn it over to Bill now, who's going to go through a few additional studies. Oh, sorry, Bill, do you want me to continue to advance the slides, or
no, I just need to. I'm gonna take over.
Okay.
So first, I'm going to talk about an Australian study, and this group has reported twice on their experience with transmission of COVID in school settings at the beginning of the pandemic. This particular study that was recently published. Let me see if I can get this a little bit bigger here. I'm going to move you. Sorry. So this was published recently on August 3rd, and they looked at over 25 primary, secondary, and early education schools in the New South Wales area. And they found all children who were diagnosed with COVID at the onset of the pandemic, and as well as adults in the schools diagnosed with COVID, and looked for attacks rates and transmission within the school. This is the summary data. And there at the bottom of the page down here, you can see that there's this one single episode. There's a daycare or early intervention program that had a complicated situation, and they're not quite sure what happened there. But if you look at all settings, all contexts, you can see that there's a really low transmission rate in the school setting. And this is for both adults and children. And if you look up here, all children, all child case to child context, you can see that children just are not transmitting their disease. So the attack rate was only 0.3%. There just wasn't much transmission from children to adults. There's a touch more adults to adult, as we just know from our baseline epidemiology. And so this is just reassuring data. Their conclusions were that, again, as we've seen in other school settings, that there's been a pretty low rate of pediatric disease. And they're pretty confident that the children, and these are children of all ages, they included secondary school, primary school, but a little bit heavier weighted towards the younger children, seemed unlikely to initiate or propagate outbreaks. They just weren't seeing that very much at all. But they did say they had a very effective state, national, and community responses. And again, so that may not be totally applicable to all parts of this country. This data is really consistent with lots of other school data from the onset of the pandemic. So in this box right here, the first purple guideline here, you can see that there's data from Australia, Ireland, France, the Netherlands, Norway, Finland, and Singapore, where at the onset of the pandemic, when they identified children who were COVID positive, there was remarkably little transmission in the school from children to other children or from children to adults, all very consistent. It was really hard to find a single case of a child transmitting to anyone else. Interesting enough, we actually have data from reopening schools. So again, people are saying often, are we guinea pigs or something else like that? And the data here is also really, really assuring. So if you look here, this is after reopening. So this is not the beginning of the pandemic. This is during the pandemic, and they're opening schools. Sweden, Germany, Finland, Denmark, Netherlands, and Quebec, Canada all had really reassuring experiences. They were not seeing outbreaks. They were not seeing an uptick in prevalence rates in the community. This worked very well. Again, these are all areas where they had low prevalence rate, similar to that in Vermont, and worked well. I should say that in areas where there's been a high prevalence rate, or there's lots and lots of transmission in the community, things have not gone smoothly. The country that's prototypic for that was Israel, when they opened suddenly and opened all bars and schools at the same time, and were unable to mask and keep distancing in the schools. They actually abandoned that. There were lots of outbreaks in the high schools. And of course, if you've read any of the news reports, things have not gone swimmingly in Georgia and Mississippi. Again, tremendous high prevalence rates in the community. And again, schools will just reflect what's going on in the community. So children were literally entering school with COVID. I mean, there's a classic example in Indiana. Someone was tested for COVID like a day or two before school started, entered school, test results are known like noon the first day of school, and immediately they have to begin quarantining. Hundreds of children in Georgia and Mississippi are now COVID positive. So this is a huge study. It's not all that new at this instant in time, but I put it up there because this South Korean study about transmission in household contacts really is the basis for many of the recommendations for under 10 is safe and over 10 is not. I'm going to explain that in a little bit. So the Koreans were very aggressive about contact tracing. And this is based on almost 60,000 contacts of 5,700 infected people in South Korea at the onset in the early parts of the pandemic. And here's the key data. So you can see that in the 0 to 9 group right here, 0 to 9 group right there, they did not identify very many people who were COVID positive, again, showing low prevalence rate in pediatrics, and that they did not easily transmit disease to other people in the household. So the transmission rate in the household is only 5.3%, and again, very low in non-household contacts over here. This is where all the action was in the newspapers. The 10 to 19-year-old group, they had a much higher transmission rate, similar to adults. And this is why you saw the headlines where that children 10 to 19 are as effective as adults at transmitting disease. A couple caveats to remember. This is the household contact data right there at 18. But the non-household contacts, non-household, they were not very efficient at all, much lower than older adults. Secondly, 10 to 19-year-old children is a really broad range. You know, a 10-year-old is like a 4th or 5th grader, and a 19-year-old is a college freshman. They are really radically different people. And two, there are far fewer contacts in this group that were followed. So a little bit of funniness here, not quite sure how to explain it. I think the take-home message here is that young children seem unlikely to transmit disease compared to adults. They're much less efficient at that, but there's probably an age continuum. At the older you are, the more closely you resemble adults and the more likely it is that you are going to transmit like adults. So that has implications, particularly at the high school and college level. So this was brought up in the chat box. This just came out a short while ago, and this is basically how well do masks prevent droplet transmission. And this is a study not involving patients at all. They just developed a mechanism to figure out how they could actually model whether or not these masks were efficient at preventing droplets. So it wasn't as if they put a machine in front of people out in the street at Burlington or something else like that. And here is the key data slide. So they measured droplets, okay? This is the relative droplet count on the y-axis over here, relative droplet count. And here are the different types of masks. So fitted N95 mask, we know is a really efficient mechanism to prevent inoculation in those and to prevent transmission of particles. And then you have a surgical mask down here, and way over here, and my pointer's not working quite as well as I hope, but you have none second from the right. So here's some really good news. Almost all these things here were really effective at preventing disease transmission. Look at all this. This is all really good at preventing, not disease, but droplet transmission. That's really great data. It's only when you get up over here, so if you look up here, this is, I'm gonna have to drag it all over here. Up in here, this black bar is the fleece, that single layer fleece. It didn't perform worse than none, but certainly was equivalent to none. So that's why people are thinking very carefully about whether or not gaiters are appropriate. And I think we saw in the chat box that I think one school nurse were saying that they're not going to allow gaiters. That'd be very reasonable. They are not, they're not providing any benefit based upon this study. Now, it's not just a single study, but right now the data would suggest that fleece, those single layer fleece gaiters should not be used. There's been a huge amount of debate about whether or not COVID or SARS-CoV-2 is transmitted by aerosols. The World Health Organization received a letter from, I don't know, a couple hundred scientists saying that you have to declare that it's transmitted by aerosols. That's based upon somewhat about the data from a choir in Washington where they sat in a room for 2 hours and sang, and there was a high transmission rate. But it's been really debated about how much of the disease is transmitted by aerosol. This got a lot of play, and even the New York Times said, this is the dagger, this cinches the argument. I would be a little cautious about saying that. So here's the data. And the saga is that they measured viral particles in a room with a patient, in a patient room who had COVID. But what's not apparent in the headlines is how difficult it was for them to do this. They had to really concentrate this. They had to concentrate it many times. And it turned out the first few times they did this experiment, it failed because their cell lines were contaminated by other viruses in the air. Again, suggesting any virus can go up in the air for a short period of time. So you just have to take this with a huge grain of salt. It just means that if you work really, really hard at it and really, really, really concentrate the air and really try to get rid of every other single virus, you could have some viral particles in the air. I think my take-home message from this is that the major, I still think that the major mechanism of transmission is droplet. Can there be aerosol transmission? Well, sure, under certain conditions that favor that, there can be some aerosol transmission, but that is not going to be the dominant form of transmission. So this report got a lot of data, a lot of attention when people saying 50% increase in pediatric cases or 90% increase in pediatric cases. This is a collaboration between the American Academy of Pediatrics and the Children's Hospital Association. This is just hot off the press. I think this morning, the version 8.6 was just released. So basically,
Dr. Raszka, I'm sorry to interrupt, but your mic is cutting in and out ever so slightly. I don't know if you could go just with your mic on your computer instead of your headset. I don't know if that would help or not.
All right, I'll try to keep my head steady. How's that?
Oh, thank you.
I suspect. So what this slide just says that in the most recent data is that children are now making up a higher cumulative percent of the total cases of COVID than earlier in the pandemic. And right now, about 9.1% of cases diagnosed in the United States through August 6th are in children. Now, that's still underrepresented in the sense that pediatric population is 22% of the US population, but nonetheless, there's been a significant increase in the numbers. And there's several reasons why there's a significant increase in numbers. This is not surprising. There has been a massive uptick in the number of infections in the United States. So at the time this data was being accumulated, there were massive numbers of adults in Florida, Texas, California, and other states with diagnosed infection. Children are not immune to COVID. So the prevalence rate in children will mirror that in the general population. So that is not surprising. Two, there's a greater interest in testing children. And so there was, earlier in the pandemic, we were only testing those that were most ill or most severely ill. And children don't develop nearly severe disease nearly as often as adults do. So there was just less testing in children. So this reflects a bit of a testing bias in children. And of course, when you're entering school and camps, a lot of children will be tested. So again, reflects a different strategy for identifying people. I would say, however, that children still are much less likely than adults to develop severe disease, that a modest number of children hospitalized. I'm not saying that they can't develop severe disease, but you can see the hospitalization rate in children with COVID is around 2%, and the death rate is really very, very low at 0.02%. This is the Vermont data. This was accessed a couple hours ago. And you can see that there have only been 49 children, 0 to 9, diagnosed with COVID-19 in Vermont since the beginning of the pandemic, and twice as many in the 10 to 19 group. No child with COVID has been hospitalized in Vermont, and no child has died from COVID in Vermont. And I'll just finish up with some testing. This was a headline that got a lot of news. It's just amazing, test positive, then test negative for coronavirus. How can this happen? And it really depends upon which test kit that you use. So there are several ways that you can test for COVID. What we have primarily been talking about are the molecular tests, such as reverse transcriptome PCR. And those are the tests, usually there's a nasal pharyngeal swab, or you could do the anterior nares. Occasionally, you could even do sputum. But most of the time, in Vermont, we've been using the nasal pharyngeal swab. And these have high sensitivity. And the test characteristic itself, you can detect a tiny number of virions in the DNA or RNA in the nose with these tests. So they have high sensitivity. There are problems with sensitivity if you don't do the test correctly or it's not processed correctly. And that's why you've heard of reports that maybe you may have false negatives with that. But the test has high sensitivity and high specificity, but it's not a point of care test. It takes a bit of time to get those results back. What you have heard a little bit about are these antigen tests, and that's what the governor of Ohio had. He had an antigen test, and that's a point of care test, and it's just looking for pieces of the virus. These absolutely have poor sensitivity. And although the original emergency authorization use, they said that they had high specificity, those were in highly symptomatic people. We have internal data here and in Maine and other places that there is clearly a problem with specificity, remarkably poor specificity in asymptomatic people. That would also suggest that there are problems with the test characteristics. So we only recommend these point of care antigen tests in people who are highly symptomatic, where you need to make a decision really quickly. They are not for routine use or for screening. And of course, serology is not useful for acute diagnosis. So that's what I have for my presentation. Now we're going to be happy to answer any questions that you have.
Great, thank you guys so much. I appreciate too that you have put some questions, some answers in the chat box. As a reminder to everyone, as we have done since March, this presentation will be recorded and posted on our VSSNA.org website. If we don't get through all the questions that we have today, we will get those answers from the docs and make those available as well. So we answered the first question on my list was about gators, and I think that's been answered. But we have some questions about the NASM guidance for healthcare personnel says that wearing a face shield does not provide full protection from respiratory droplets. I know that that speaks to healthcare settings, but the new guidelines from that came out the other day, there is no clarification for the need to use a face mask with a face shield. Do we need to inform the staff they are not protected from droplets, and should we even be allowing face shields?
We have a strong preference that people should be wearing facial cloth coverings or what we would call procedure masks. The procedure masks are the one that hook on the ear. We think that is the best way to protect staff in the building. We also think that when staff are going to be with children who cannot control the respiratory secretions because they are not masked or cannot be masked for some of the reasons, that they should have additional protection for their eyes. If for whatever reason a staff should not or cannot wear the surgical mask or the procedure mask, then face shields that go beneath the chin and wrap around the sides are a viable alternative. So it could be that you're a speech pathologist or a language specialist, and that child really needs to see your face. So you could potentially use that, or you could use one of the clear masks. Unfortunately, the clear masks are in super short supply, so I think it's more likely that you're going to use the shield. That would be an acceptable alternative, but it should not be for routine use. That has been our general recommendation.
Okay, thank you. What about therapy dogs in school? Clayton, you want to put some extra information on that one? Or Dr. Lee, do you have an answer?
So I think that when the question was asked, it was about therapy dogs, but it got me thinking about service animals and the question of ADA versus something that's not protected by ADA, and whether it's a volunteer versus it's staff in the school. So but I think the big part is, are dogs considered a vector? And if the answer to that one, so if the answer is no, then do you have any more guidance about the difference between a therapy animal versus a service animal?
Yeah, so my full disclosure right up front, I am in every sense of the word a dog lover, so maybe my response is a little bit biased, but I don't think that we have any evidence that pets have been serving as vectors. Early on, there was concern that, you know, the main concern with animals had to do with what we call fomite-based transmission. Could there be virus on the fur or on the hair, you know, and could that virus be transferred from one person to another via that route? The longer that the pandemic has gone on, I think there's been greater and greater recognition that that route of transmission really doesn't appear to be very important. And the types of surfaces that are the least able to support virus from persisting are organic surfaces. So, you know, things with fibers like hair and cloth and that sort of thing. So I personally would feel fine with service animals and therapy animals being in the school environment. I will say I don't know, in full disclosure, if there has been any guidance on that from health department or AOE, but just from an infectious disease risk standpoint, I think the risks are pretty minimal there.
Thank you for that. Very much appreciate it. Here's a good one for you guys. How confident do doctors or epidemiologists feel that the transmission of COVID-19 of children under the age of 10 years old is minimal? Is there enough data? Do you expect to see any change in this data as schools reopen?
So I'll take that one. So here's what I say all the time. We have to be humble about what we know and humble about what we don't know. It is a very fluid environment. Things change all the time. Based upon our current understanding of the data, it would seem that younger children, particularly younger children, are less likely to transmit the virus that causes COVID than adults. We're not saying that they cannot transmit the virus. We're just saying they seem less likely to. And that's based upon household contact studies and school studies. So right now, I would say that children, you know, particularly younger children, are unlikely to be drivers of the pandemic compared to adults.
Thank you. That goes along with another comment that someone had made or sent in. Teachers are extremely concerned that the students who may not be wearing a mask for whatever reason will be the reason that they get sick. Remember, you're talking to us scientists here. So what suggestions do you have for us to respond to those teachers and other folks that don't see the science?
I'll continue this and I'll let Ben chime in after. I would say it's likely that the adults will transmit to the children based upon all the data that we have. And I think something came up in the chat box. I really think that adults, as best they can in the school, should stay at least 6 feet apart from each other. I think that adults in the entire community should stay at least 6 feet apart. I think the adults in the school should definitely be masked. I'm actually very supportive of masks beyond facial cloth coverings, based upon the National Academy of Sciences suggestion that they wear procedure masks. So I'm comfortable with that. I think that even for temporary close encounters, that's not a true exposure. You have to be close for 15 minutes without the masking. That's where a potential exposure could take place. And I'll let Ben chime in.
Yeah, sorry. So if I was in the middle of typing a reply, so I just want to make sure I understand the question. Can you repeat the question for me?
The gist of it is teachers are extremely concerned that they will be getting COVID-19 from a student who is not masked, because so the question is, what are some good responses for us as school nurses who understand the science to be able to share with those folks about their concerns?
Right. Yeah, and I think I'll probably just reiterate, I think what Bill was stating and getting at is that, you know, we know that there are going to be those scenarios where there are some children who either, you know, who won't be able to wear a mask or can't tolerate a mask. And, you know, I think just really the best we can do is to say we can apply the strategies that we know work, you know, as best we can. So having, especially for those staff or teachers who are going to have a higher degree of contact with kids. So maybe people who work with kids who may have special developmental needs or certain medical needs, that trying to protect them to the extent possible. So that could include stepping up to eye protection and, you know, either surgical or KN95 mask, and still trying to maintain distance whenever possible. You know, converting any types of educational, you know, those interactions that could be done from greater distance, trying to make sure that accommodations are made to do that. And then with the recognition that when there are those moments where there do have to be closer periods of closer contact, that that those teachers are wearing masks and eye protection. And I think that's sort of, you know, that's what we do here in the hospital setting. When, you know, when we're evaluating a child who can't wear a mask, then you know, we make sure we have at least a surgical mask and eye protection on.
Thank you. Appreciate that very much. Here's one we're all wondering about. How will COVID-19 change the flu season scenario when it arrives?
So really interesting. We have no really good idea what flu is going to look like in the Northern Hemisphere this year. There's been remarkably little influenza activity in the Southern Hemisphere. And usually there are cyclical waves, northern, southern, northern. So we're not entirely sure. However, it is a huge fear in the infectious disease community. To help mitigate some of that, we're actually going to recommend that children be vaccinated against influenza a little earlier than usual. And then hopefully we can prevent as much influenza as we can. That is the goal. If there's widespread influenza circulating in the community with COVID circulating with other respiratory viruses, it's going to be really challenging to distinguish between them, and it's going to be really challenging to have adequate test capacity.
Thank you. During our facility meeting yesterday, a staff member asked if during the temperature screening before school, his or her temperature reads 100.5, and they state that their temperature, quote unquote, usually runs high. Are we allowed to check the temperature again, or is it a one and done type of situation?
Yeah, I mean, I think these little conundrums are sometimes pose the greatest challenge because it's not quite clear. There's no definite answer or guidance. You know, the concern was raised earlier in the summer for other locations that were doing temperature screenings at, for example, workplaces or whatever. You know, even just being out in the hot weather could potentially cause falsely elevated readings. You know, I do think that I think we need to be careful about assuming that any elevated temperature is just because that's what any individual child does. Because I think that's a pretty slippery slope to go down. If it's 90 degrees out and we're seeing that you're getting a number of high readings, then I think it is reasonable to say, well, let's let the kids have a moment just to cool off and see, because especially if you're doing like a touchless temperature, those can be significantly affected by environmental extremes. But other than that, I would be very cautious about assuming that this child just always runs high anyways.
Okay, thank you for that. This question,
I'm sorry,
ahead.
just wondering if the follow-up is, it was a question about a staff member who said that as an adult, their temperature runs high. And so would it be retake the temperature, or in the time of a pandemic, would we make the consideration that 100.4 is the cutoff and they need to go home until something was then discussed about the possible condition.
Yeah, I guess in the absence of any, I guess I would be uncomfortable with accepting a kid into the school with a temperature of 100.5 based solely on, a report from home that the child's temperature normally runs high. I was, yeah, I guess maybe I'll just leave it at that. Yeah.
So perhaps we should consider the same thing for adults. Sounds like the answer to that. Let's make sure we know before we get generic, I guess.
Yeah, and that doesn't mean that, there couldn't be a possibility for further discussion with a provider or what have you, but, I would hesitate to, say that would be an acceptable allowance just, based on self-report or something of that nature.
Thank you. This is about cleaning. The specific cleaning instructions when there is a confirmed COVID case is clear, but we won't have confirmation for at least 24 to 48 hours from when the person left the building. That feels a little late to start ventilating and cleaning spaces that have been in continual use. Can you share your thoughts?
So the question is, are we waiting too long to clean the rooms, or?
Yes.
So I think that in every single school district meeting I've been at, the people who are in charge of environmental cleaning have really had really nice plans. They are actually cleaning the rooms every single day. They're not waiting 48 hours. They're actually cleaning it every single day. So I think that the schools have good plans for environmental disinfection, to be honest with you.
Great, thank you. If there is a positive case and a class is sent home for 24 hours while contact tracing has begun, would every adult who had been in that room need to stay home? For example, a special educator or an art teacher who may have moved in and out of that room during a day.
So part of this will, the sort of recommendations for who needs to quarantine automatically or, be excluded automatically, while the process plays forward. A lot of that will be determined by the health department. But in general, brief contact would not likely be a reason for automatic exclusion. And so that would include somebody who happened to be in the same room potentially for a period of time, but wasn't in any type of prolonged close contact with the person who's being evaluated or tested. And so it really would be, there may be scenarios, and I believe that the epidemiology group at the health department, they're still in the process of sort of putting together some more formal sort of language around this. That it could be that, anybody who's like homeroom, for example, maybe there's one day where they may need just time to sort of sort things out and that type of thing. But anybody who had any type of casual contact wouldn't necessarily be included there.
Great, thank you. I think that's a good reminder for all of us that we have to pay attention to the specifics. Questions about the impact of mixing cohorts for before and after school care. We're taking great care to keep groups small during the day and would like to be able to offer before and after school care, but are worried about the challenge that might make for contact tracing should there be a positive case. Of course, if there's no aftercare, kids will be going somewhere and they just won't be on campus. Thoughts on that?
So I keep on thinking of this as a continuum, and that you really can't separate the schools from childcare, just like you can't separate childcare and schools from the community. So there's going to be contact outside the school. And we're doing lots of really cool mitigation strategies in the school. You're doing lots of cool mitigation strategies in childcare, and hopefully the community continues to do mitigation strategies. But you're going to try to minimize the mixing as best you can. I think it's going to put enormous pressure on families and schools if you're only in person a short amount of time. And then the children, particularly the younger, will have to go someplace. There was a really interesting discussion with an epidemiologist from the Harvard School of Public Health who said, from his perspective as an epidemiologist there, that hybrid models potentially a higher risk because the students are only in school for a certain amount of time. That means they're going to have an additional contact, that they may have a contact at a childcare facility or some other facility and the community and the school. That's just a pure numbers game. We're not saying it's going to happen. We live in a low prevalent state, so we're really fortunate. But I just hope that everyone can work together. That's the key thing, that we all have to think we're a continuum.
Great, thank you. I would love some advice on the best way to respond. Oh, we already answered that one, about the research that shows lower transmission with kids. All right, advice on the best way to respond to those who claim we are putting teachers' lives at risk with, and statements like how many people have to die, etc., by returning to school.
So I mean, this is very, clearly it's a very emotional topic. You know, there is anxiety, and there's no denying that. I think for me that the challenge that I often, the challenge for me is that, you know, the reality of life in the United States in August 2020, and most places in the world is that, you know, unfortunately there is nowhere where we can provide an assurance that this setting, this venue, these conditions will 100% guarantee that somebody couldn't, you know, catch the virus or get sick or even, you know, unfortunately have a bad outcome, like somebody who gets sick enough to die. And so, you know, I think that it's maybe a bit of a harsh reality for me to put it that way, but I think it's true. I think the idea that we can only go back to school if we create an environment where we can guarantee zero risk, that's just not a realistic or attainable goal. Just in the same way that we can't say that there's zero risk if somebody goes to the grocery store, goes to the hardware store, goes to fill up their gas. Unfortunately, until this entire nightmare is behind us, there's no scenario where we can say we can create an environment that has that degree of safety. And so I think that if that's the benchmark that we're shooting for before we say that we can reopen the schools, we're just never going to get there. What we're basically saying is all schools should be closed until this entire pandemic is over. And personally, as you know, both as a parent and as a pediatrician, I think really our responsibility is to figure out how can we make sure kids can go to school in as safe of a manner as possible. Because I think the potential fallout of having kids all across the country be out of school for you know, all year would just be disastrous in ways that we can't even necessarily predict or comprehend. And so you know, recently in the news, it's come out recently that there's a new outbreak in New Zealand. I mean, talk about as remote of a location as you can get, but even there, you can't be completely guaranteed or safe from having cases crop up. They had over 3 months without a case, and they have, for all extents and purposes, pretty much closed borders. It seems most likely that the virus got back in through somebody who had to travel for an essential reason and managed to slip back in that way. So the idea that we're ever going to reach a scenario where we can guarantee that there won't be any infections or people getting sick, unfortunately, it's just not realistic. And I don't think that that is, I think we need to figure out a way, how can we do this as safely as possible? You know, both for our kids and for our communities. I will say, and we say that both Bill and I and Brina, we say this all the time, there's nowhere safer in the United States right now than here in Vermont. And so sometimes it's easy to forget that when we see all the national media that goes flying around. But once again, there's nowhere safer in the United States right now than in Vermont. And this is, we should feel lucky, not rest on our laurels, because it requires ongoing vigilance, but recognize what a unique opportunity we have here to reopen the school safely. In many places, places where parents are desperate and children are desperate to get back into school, it's just impossible to do because it's so unsafe right now. Here, we can do this, and we can do this safely.
Hey, Soph, can you guys hear me? It's Brina.
Yes.
I did want to say one thing. The question before that one, which was sort of our great school nurse colleagues with scientific backgrounds wanting to sort of digest the research and have sort of talking points or ways to talk about that. I heard that request. I think we can really honor that. I did want you all to know that we think we're the only state in the country that we had infectious disease doctors on our task force to reopen schools. And like, we are so lucky in Vermont. I like to think it's our size, but it's more than our size. It's this collaborative partnership and this commitment to science. So it just seemed like a good opportunity for me to tell you all that from my perch as a pediatrician in the administration, this is a completely scientific decision. This is not a political decision. And I don't know if that makes it out into your world, and you guys don't know me well enough to know how authentic I am, but I just really want you to know Bill and Ben don't have any connection to the administration. And, it's all about the science. And I hope that's visible. And I think you as our health partners could help us get that word out. Look at who was on the task force. It was half physicians. That's unheard of, right?
Thanks for that, Brina. I appreciate that. And thanks for reminding us too that we are the professionals in our schools, and we can speak strongly to the coworkers that we have, you guys, and your commitment to the children of this state. And knowing that you're following the science, you're giving us the information on the science, and you don't want these kids in any more danger than we do. So we're all on the same side, and we can use our school nurse voice to spread that and share that. So thank you, Brina. I appreciate that. Let me see what else is here. If a child has a documented medical exemption from a doctor to not wear a mask, what alternatives are there to protect other people if children are not wearing shields? And let me put the follow-up part here as well. There are parents who are concerned about their child being in a classroom where another child has an exemption and won't be wearing a cloth face covering.
So I expect that during the school year, there will be children that will get an exemption. They should actually be very few in number. The medical community has been very clear that children with chronic medical conditions can wear facial cloth coverings, and they, just because of a medical condition such as asthma, are not exempt from that, and they should do well with that. If a person with asthma really can't wear a facial cloth covering, they need to see their pulmonologist or check in with their pediatrician right away because their asthma is not controlled. If for whatever reason a child truly can't wear a facial cloth covering, then the second option is a shield of some sort. If the child can't do that at all, so the child is in the room completely unmasked or without anything to prevent spread of droplets, then it becomes really imperative for everyone around that child to have their protection. So they really have to make sure that they're wearing their facial cloth covering, that they're washing the hard surfaces and washing their own hands aggressively.
Thank you. I think he answered this plexiglass question in the comments. One of you guys on my team that have been monitoring the chat, is there anything we should bring up specifically? We're almost at our time frame.
So, but yeah, I think everything that we've captured here has been answered. There may be some new questions in the chat that we haven't been able to bring over yet.
I was wondering if maybe either Dr. Raszka or Dr. Lee had any insight on some of the questions that they've been answering in the chat. I've got a couple of messages from other folks saying it's really hard to watch the chat and hear what's being said. So if you have any key things that have popped into your mind that weren't covered specifically in what was spoken, it would be really great to hear those. So folks have, we're gonna have the chat later, but it'd be really great for them to be able to hear that now.
Thanks for that, Clayton.
Ben, do you have comments first?
Sorry, I was.
Yeah, we are monitoring to the chat. So I think that a couple things have come up really, like I just see some of them bathroom procedures. I think you should flush the toilet.
And then wash your hands.
Yeah, and wash your hands. But it turns out, you know, like there have been articles saying that these things can be aerosolized and, you know, it's a risk of transmission. You know, they have found some particles of RNA in stool. I just don't think that flushing toilets is a major mechanism of transmission. Just flush the toilet and wash your hands. A really interesting issue that's going to continue to arise is what to do about singing and instruments. That we had been very cautious about that, and that we had thought that indoor choir, glee, singing would be a higher risk situation, and we thought that we would be cautious about that, or actually not even do it. Since that time, there's a study that was done by a group of music teachers and choir at a national organization that said under certain conditions, certain instruments where they had a cap and a bell and a couple other things, it may not, you may not aerosolize things. We have to digest that data and see what that's all about. But right now, at this instant in time, we're saying that singing in closed environments is a high risk situation, and we would not support that. If you want to go outside and sing and stand 6 feet apart, I feel much more comfortable with that. If you want to go outside and do the marching band and you're far apart, I'm okay with that. I just am extremely worried about indoor activities, and I just don't know the data yet about what things you can put over these instruments to potentially decrease some droplets.
Can I just make one more point? I promised I wouldn't speak, and then you knew this was going to happen. But the music teachers in Vermont are extraordinary. And what I love is everything Bill said is true. We have clear guidance about chorus and woodwind brass, but they still wanted to try. And so they put forth as a group some ideas, and they're kind of wanting Bill and Ben to review the literature and see if there's any wiggle here. And so to me, that's this collaborative spirit again, right? We're not in this sort of, you know, line in the sand space, but we're just trying to move ahead with what the needs of kids, the needs of our teachers, and the science. So that just felt very positive to me, that it wasn't just the guidance went out and everybody just shut down singing. It was thinking about what singing does for kids, how it brings them joy, how can you get kids outside. And so just another little Vermont moment.
So, Soph, well, I was wondering if either Dr. Lee or Dr. Raszka could maybe talk about that, the PDF they shared about the masks that was done by UVM. I didn't know if they had it available to bring it up and then kind of scroll through and talk about it and share their screen, or I could share mine and you could talk to it.
Let me pull it up. It'll just take a second.
Okay,
and,
thank you.
Thanks for reminding me about that, Clayton.
Desktop.
Hold on to your seats.
I'm going to make the
Attendees.
observation that Dr. Raszka's technology skills have increased exponentially since March. Very good, Bill.
All right.
And I would mention that the VSSNA is looking for additional IT folks. So Dr.
Oh, good.
Bring it on.
All right, so we're going to share my screen. Can you see it?
I'm unmuted.
Can you see the screen now, Clayton? Uh-oh, I don't hear anyone any longer.
Yes, we got it.
Screen.
Oh, good. All right. So this was the pediatric, so I have to be very careful here. This is the Pediatric Infectious Disease Service, which is an august service consisting of 2 people, Ben Lee and myself. And we put this together to just, and it's basically because we had heard a lot of conversations about masking at different meetings, and there was a bit of confusion about this. So this is not a Vermont Department of Health document. It is our document, although many people have had input into this document. And basically this is, we just walk through what a facial cloth covering, and you know, there's just a sentence down here where you just say, we really think that these should be at least 2 layers. And this was even before the study came out about the gaiters. And this addresses that those gaiters, which are fleece, we don't think are going to be as effective. But the 2-layer facial cloth coverings, as we saw in that study, actually work very nicely at preventing droplets. Facial cloth coverings are not considered personal protective equipment because they are simply designed to prevent transmission to others. A thicker, you know, a double layer or triple layer like the governor's wearing will provide some protection for the wearer, but that's not what it's actually designed for. It's designed to prevent transmission. Everything else that we're talking about will help prevent transmission, but will also help prevent infection in the wearer. So this technically is a picture of a standard procedure mask. Surgical mask and procedure mask are terms used interchangeably, but very technically, a procedure mask has loops over the ear, whereas a surgical mask has the ties. And these are usually 3 layers, 3 thin layers, but together a fancy material. But it prevents droplets from reaching the nose, both by physical barriers, but also by static electricity, interestingly enough. And these actually are pretty good about preventing droplets from reaching the nose and the mouth of the wearer. You know, these are loose fitting, so you can see on the side here, it's a little floppy there, so it's not going to prevent aerosols, and some things can leak in there. But nonetheless, it's modest protection, and this is what we wear in the hospital environment at all times, to be honest with you. Again, the National Academy of Sciences does recommend this for adults in the school environment for a couple of reasons. Not only does it help prevent transmission, but again, it's helping prevent infection in that person. This is an example of the clear mask that I talked about. This is really designed for special educators, developmental pediatricians, or others, where it's really important for the listener to be able to see the mouth. Unfortunately, these are in really short supply. There's a tremendous shortage. We can't even get them for our developmental clinic, but those are very handy. So not only would they help prevent transmission, they help protect the wearer, but you'll be able to see the lips move. Personally, I think they can look a little scary, but that's based upon the reports from our developmental pediatrician. So then you get into these things called respirators. And again, we don't really talk about the term respirator, but basically these are devices that not only protect against droplets, because so far we've only talked about droplets, but smaller droplets and aerosols. So respirators are designed to help prevent against the tiniest particles. And there are a lot of guidelines about this. So the National Institute of Occupational Safety and Health evaluates, tests, and approves these things. They don't regulate medical devices, but they have to sign off on these things. And I put this picture up here. This is what we call medical grade fitted N95 mask, fitted. What it means is that this actually has a very specific shape to it, and it has 5 separate sizes, generally speaking. In order to be fit tested for an N95 mask, literally you have to try on one of them. You can't have much facial hair, and you have to be in a little tent with saccharin. And if you can smell the saccharin or the sweetness, then the mask doesn't fit you well enough. Literally, if it fills the thing up with gas. So that's a fitted N95 mask that is very effective at preventing droplets and aerosol from reaching the wearer. And of course, it would be very effective at preventing transmission. They are a bit thick. There are at least 3 layers of cotton. They're hard to breathe through. They're hard to go upstairs in for sure. And I just put some information here about what these letters mean when we talk about N, R, P, or K. The N95 mask is just says it's not designed to prevent oil, things that are immersed in oil. That's all. But it doesn't have anything to do about the efficacy. And the 95 means that it will filter out 95% of a cloud of 0.3 micron particles. So pretty effective. What you've heard about is this K in the school. The K actually refers to the Chinese standard for this. There are New Zealand standards, there are Chinese standards, the European standards for these types of masks. The K just refers to the Chinese standard, which may or may not identically match the US standards. So KN95 masks, let's see if I can get a photo here. This is a KN95 mask here. It tends to have a slightly different shape to it, but they work well. They're not fitted, so theoretically you can have a little bit of leakage around there, so they may not provide quite the same protection as a fitted N95 mask, but will provide more protection than a regular run-of-the-mill procedure mask. This is a standard N95 mask that you can buy at a hardware store. There's no routine use for it. It's not fitted, so there could be a little leak here. And this is the valved mask right here. Those valves, I don't like those valves. You can buy masks with the valves, but they are really designed for construction workers who needed a fairly high degree of protection, but against dust and particles, but need to make it easy to breathe out. Remember, if you can breathe out, if you can exhale through that valve, that means that you're not protecting those in the community. This type of mask is only designed to protect the wearer. Fundamentally, we think everyone should be in the school wearing some sort of facial cloth covering to protect everyone else. So when someone wears this type of mask, this valve mask, they're deliberately saying, I am not trying to protect you at all. So I don't think those masks should be in the school at all. And then we just have a summary, facial cloth coverings, they protect other people. They don't protect the wearer very much. They're not fit test, but they are reusable, but they should be washed every day. The procedure mask, and they protect other people, moderate protection, they're not fit tested. Theoretically, they're not reusable. I got an email, I think today from Sophie, like, well, in a time of shortage, could we reuse the procedure masks? There is guidance to reuse the procedure mask during the day. There's no particular guidance about using it on subsequent days, but you'll notice that from like 20% of cars in the Burlington area, instead of having dice from the rear view mirror, you have these procedure masks. So as long as they're not soiled, as long as they're not ripped or torn, as long as they're intact, as long as they're dry and have been handled properly, they could potentially be used another day in time of scarcity. That would mean that you would, and I think there might have been something in the chat box while I was talking, but I can't be sure, but again, they have to be folded along longitudinal axis, and you would put them in a brown paper bag or hang them someplace where they could dry, because the virus will not remain viable on that surface for a long period of time. Here's the KN95 mask, moderate to high protection. And again, I made sure I put this in here because I think a lot of the schools have a supply of KN95 masks that have been distributed to them. Again, there's no general recommendation, but perfectly fine to use. It'll give you more protection than a procedure mask. And then of course, then you have the fitted N95 mask. This is really designed for medical environments. They're very special circumstances where school nurses may need to use them, but they're not for general use. And you are welcome to share that with whomever you would like. So I see.
Thank you very much.
I see Mandy. I would say that in the general community, surgical mask and procedure masks are used synonymously, but technically they're different, but we're going to use them interchangeably.
We have another question. We might be able to get answers to two questions. This one is, if students come to the cafeteria with their cohort in order to pick up pre-ordered meals and then take those back to the classroom to eat them, is that okay? The thinking is that this service model is easy and would alleviate the need for additional USDA training. Your thoughts on that? Yeah,
so if I'm understanding correctly, so everybody would pick up their lunch and take it back to the classroom and eat it there. That is an option for as a way to reduce sort of mixing in cafeterias and keep pods and cohorts together. Probably even better would be if, and again, this just logistically may not be feasible in all locations, but if the lunches are even brought to the classroom, so or if a schedule is set up so that you just don't have lots of kids passing each other in the hallways. But yeah, I think moving lunchtime into the classrooms is a good idea.
Thank you. How about addressing in the next few minutes, maybe, we've talked a lot about children under the age of 10, but there are obviously those kids between the age of 10 and 18 that also are still in school, and they're just kind of whole different animals. Can you speak to that middle school, high school age group and transmission and protection for them as well?
So we have assumed that children can transmit disease. Younger children seem less likely to transmit disease. We've assumed that there's an age continuum, and the older you are and physically more mature you are, the more likely is you're going to act like an adult. So in theory, that high schoolers are more easily able to transmit than elementary school transmission. And of course, high schoolers will have different types of activities. Very unfortunately, around the United States right now, it's these older teens and younger adults that are congregating together because they're just so sad about being isolated, that leading to hotspots of infection. So I think in the high school setting, it becomes even more imperative that people really are masked at all times, that we really are very thoughtful about our physical distancing, that we make sure that we're careful about the hallways and the staggered start and stop times, that we really think carefully about who's moving. Is it the teacher moving or the students moving? And I know they have different, setups, but we just are going to try to minimize the contact between high schoolers and adults and high schoolers and other high schoolers as much as we can.
Thank you. I'm sorry, there was a question about students with IEPs, and I scrolled past it. Does anybody have that on my crew, have that right handy so we can pose it to these guys?
Yeah, so the question was the
Sorry,
reaction.
thank you.
Students come to the, it was the health guidance be for student who needs access to their peers for more than 2 days a week in order to make progress on an IEP goals to join a second classroom cohort.
Okay,
Is that the one you were referring to?
I believe so.
Okay, Dr. Raszka and Lee, did you understand the question or do you want me to read it again?
Maybe if you could clarify, that would be helpful.
Okay, so it was, what would the health guidance be for a student who needs access to their peers for more than 2 days a week in order to make progress on an IEP goals to join a second classroom cohort?
Or would this be like a hybrid model, not a school that's in session 5 days a week? I wonder if that's what it's asking.
So I guess the scenario would be is if you have a child who's on an IEP, and as part of that, the part of that IEP involves having that child be with peers for minimum number episodes per week, and would that mean having that child join 2 different cohorts in order to achieve that? If I'm understanding that correctly. That is a great question. It's a challenging question. I think in general, so part of this may depend on the age of the child to a certain extent. I do think that our overarching goal should be how can children who need services get those services? And that should be our guiding principle, and how can we do it safely? And so I do think it wouldn't be unreasonable to try to see if there's a way that accommodations could be made for those kids who truly require that. I have less concern once again with the younger kids. Again, in the elementary school age setting, my sincere hope, based on all the science and our numbers here in the state and everything, is that those kids will be at hopefully full-time attendance, hopefully relatively soon anyways. For the older kids, then it becomes a challenge, because if it's not necessarily as clear to me if that would or could potentially move along the same timeline, if at all. But I do think if that is a service that is required for a child, then it's reasonable to try to figure out a way that that could be accomplished. And I don't know if I could really say anything more specific than that.
Okay. Thank you very much. We are out of time, and Dr. Lee and Dr. Raszka and Dr. Holmes, thank you so much. I just, I know you think I'm goofy, but I've been so excited when these guys said, yes, we'll come and talk, that the day couldn't get here fast enough for me. So your questions are great. If you still have questions that are unanswered, continue to send them to vssna.org, and we, sorry, you know what the thing is, and we will get those answers for you. And again, thank you, Dr. Lee and Dr. Raszka, so much. Very, very appreciative.
Thank you very much for including us. I echo what Brina said. This has been a great collaborative effort, and thanks so much for including us. We really appreciate it.
Thank you very much.
Mm.